I'd like to thank Dr. Gerber, I'd like to thank Jack for inviting me to give this talk. The title of my talk, I tried to get a little bit of clever, and my title is an update on ASCO 2013. I'm originally sort of a math guy, and since I'm presenting a lot of clinical trial data, I feel like I'm going to have to spend a little bit of time talking about the math, and so I entitled it Lung Cancer Math, More Division, Adding to Established Therapy, and Things That Don't Add Up. So in terms of disclosures, I have served as a consultant for Boehringer Ingelheim, and I also received research funding from a large number of pharmaceutical companies. And of relevance to the presentation from today, I will be reviewing abstracts that include drugs from Genentech, Novartis, and Eli Lilly. In terms of the structure of my talk today, I'm going to start with two separate talks that relate to biomarkers. After that, I will move on to strategies after resistance. I have one abstract that I have highlighted, but it will, in a way, serve as a representative of other abstracts as well. I also have a couple of talks of things that are additions to established therapy, and we'll end with something that is, in my view, somewhat different from the other therapies that will be described. The first portion of my talk is going to be what has become a very hot topic, which is biomarkers. Biomarkers over time has taken on increasing importance, and there are two abstracts that I'll present today which I think reach quite different conclusions. So the first one is by Leslie et al. By the Biomarkers France abstract, and the second will be looking at molecularly analysis-directed international phase 3 trial in patients with advanced non-small cell lung cancer. The first one is Biomarkers France, and I will go to this next slide. So in 2006, they show that there were a whole bunch of different ways of looking at biomarkers in France, and on some level they tried to standardize their approach, looking at 7 different biomarkers starting in 2010. EGFR mutations, gene rearrangements involving ALK, mutations in KRAS, exon 20 mutations in HER2, BRAF mutations, as well as PI3 kinase mutations. What they show here, and they are presenting data on the first approximately 10,000 patients to undergo this analysis, is they show that in about half of the patients, they are able to identify a mutation. The most common, which is what is commonly seen in clinical trials, are mutations in the KRAS gene. This is followed by mutations in EGFR genes, and then several other mutations that are also seen. BRAF, I will note, was a gene in particular where there was a study looking at BRAF mutations that was presented among the lung topics, which did show responses in BRAF-specific inhibitors in patients whose tumors harbor BRAF mutations. One other thing that I would like to point out, we have been involved in the similar U.S. effort, which is in some ways a smaller effort, the Lung Cancer Mutation Consortium. There, the percentage of mutation-positive cases were a little bit higher, but in many respects, the Biomarker France experience is probably a truer test of what really is seen in the community because it is more cross-sectional. It is not just restricted to a few academic sites, and as a result, maybe a truer representation of what is really seen out in the community. Most of these patients had a single mutation amongst these, what we often describe as driver mutations. There was a very small fraction of patients who had mutations in multiple genes. As we have seen in our clinical practice, the percentage of patients who have these specific mutations varies significantly based on smoking status. Amongst never smokers, in about 2/3 of cases, a mutation was able to be found. However, in smokers, the majority of cases, a mutation in these drivers was not found. In addition, not all mutations are created equally. So EGFR is a mutation that clearly responds to drugs that target the EGFR pathway. ALK, very similar. But KRAS, although there are many investigational drugs, it is not yet clear that there is a good targeted therapy that would be able to target KRAS in this setting. Smokers, as I say, even though almost half of them did have evidence of some mutation, as you can see among the mutation-positive patients, about 2/3 of them were KRAS mutations. and the mutations where at least there are clinically available therapies, the EGFR mutations and the ALK gene rearrangements, the percentage of those were quite low in this Biomarker France experience. This is just one example of many of the slides, but the presenter wanted to show that in many of these cases, the data was able to be used to guide therapy. And what this shows is that in the majority of the EGFR mutant patients, they did go on to receive frontline EGFR tyrosine kinase inhibitor, a drug like erlotinib or a trade name Tarceva. My guess is that, in fact, if you looked, the people in earlier cohorts tended to be less likely to get frontline Tarceva, but as time has gone on, there is better and better data indicating that that would be an appropriate treatment approach, and those numbers presumably will go up. The end result from this abstract is that there are clearly mutations that are seen in non-small cell lung cancer cases, that they can be used to guide therapy, and that there is also some data, not necessarily as part of this abstract, but related to this abstract, indicating that patients as a result will do better by those sorts of approaches.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.